Welcome to I Married a Urologist. This is a fun and educational show where the doctor's wife discusses all things urology, a taboo subject that will affect 100% of the human race at some point in their lifetime. Join host Madeline Zech Ruiz, the author of I Married a Urologist, who fixes women too, wife of urological surgeon Dr. Henry Ruiz, as she interviews medical experts, patients, and industry professionals who develop solutions for problems with our downstairs plumbing. Madeline lifts the veil to all things urology and helps us learn how to reclaim our quality of life.
Welcome back. I'm Madeline Zech Ruiz, and I'm author of I Married a Urologist. Today I am here with a fabulous guest, a huge surprise, something that we are all very fortunate to have in studio with us today. I'm here with Dr. Ian Thompson, who is President and Chief Development Officer of the Children's Hospital of San Antonio Foundation and the Christus Santa Rosa Friends Foundation. On top of that, Dr. Thompson has been a urologist for how long?
Oh my goodness.
Too long.
Since the previous millennium.
He's like caveman urologist. Yeah. Anyways, nonetheless, he is an expert in the field, and today we're going to talk about the prostate. This is a taboo subject for most people. However, today we're going to take the taboo right out of the prostate, because I'm going to ask questions that everybody wants to know, husbands, wives, men, girlfriends. But first, I want to start off, Dr. Thompson, knowing that you have such an established career. What, in your opinion, are two of your biggest impacts that you've made in the industry of urology, in your opinion?
Well, I thought it was the two biggest important things, and I would say my wife and my children,
yes.
Right? But other than that, from a professional, because your question was professional standpoint, the two probably the biggest aspects were related to prevention of prostate cancer. So I was the principal investigator of the Prostate Cancer Prevention Trial, which was a study of 18,882 men in which we were testing a medication to prevent prostate cancer. And the other one was really related to the use of PSA for early detection of prostate cancer. We've published several really pivotal major publications that changed the way prostate cancer is detected. So probably those two things.
That's huge.
Well, I had the great privilege of, I still have the great privilege of working with really giants in the medical research industry, from our statistical team in Seattle at the Fred Hutchinson Cancer Research Center to our pathology team at the University of Colorado, Denver, we had a large study where we had 5 different projects. It's called a program project grant with collaborators in Europe and Canada and Australia.
Wow. Makes
for some difficult conference calls, right? Because it's some people are in the middle of the night and so forth, but I was very, very fortunate, and still am, of working with really brilliant people.
Wow. So just so our audience knows, this man is brilliant, and he has brought so much research to the forefront and teams together so that we as the common public can understand more about the prostate. And I have a question. And because I'm not a doctor, as everybody knows, I just married one. So everybody hears the term PSA, prostate, but people like myself, we really don't know. So what exactly is PSA?
Well, PSA is it's a protein. It's a protein that's made by the cells of the prostate. If you can imagine, the prostate is a gland, so it makes some secretions that mix with the sperm and help support the sperm so that they can do their job. And PSA is a protein that helps keep the sperm alive and So it sticks to the cervix and then gradually reliquefies, allowing the sperm to progress. I think, that when you look at the way the body works, it's clear that our maker had a role in all of this. Mm-hmm. It's astonishingly complex. But what happens is those cells that line the ducts of the prostate, that make PSA and other components, the PSA can leak out of the ducts into the bloodstream. It really shouldn't be in the bloodstream. Mm-hmm. It should be very little. And if it leaks into the bloodstream, the more that leaks into the bloodstream, the greater the likelihood there's prostate cancer, because those cells, those prostate cells, they are the precursor cells of the cancer cells.
Okay.
So when they turn into cancer and then invade the prostate and then go beyond that, the more of those cells are making PSA, the more PSA leaks into the bloodstream. Thus, the higher the PSA, the greater likelihood there's prostate cancer.
Wow. Okay. So I just hear blood in urine when you talk like that, like every man. That's kind of scary to think about that. So that kind of leads me to my next question. What are some of the guidelines for screening for PSA or prostate cancer or pre-cancer?
So let's go back to your first observation related to blood in the urine.
Yeah.
Because if you look at a bunch of publications on the subject, they say, if you get up at night, if your stream's slowing down, if you have burning with urination, or if you have blood in the urine, think prostate cancer, go to your urologist or your doctor. Generally speaking, that's not true. Prostate cancer is generally without any symptoms until it spreads. Blood in the urine is almost never the first sign of prostate cancer. Difficulty emptying the bladder is generally from prostate enlargement or other conditions. It's very rare for that to be prostate cancer. So the key is that if we are going to find prostate cancer early, when you can cure the vast majority of the cases, you have to screen for it. And historically, we published a series in the early 1980s before PSA, and all we had available was prostate examination, where the urologist puts the gloves on, feels the prostate, feels for a bump in the prostate. The problem is, just like breast self-examination, by the time you feel a nodule, generally speaking, it's outside the breast, and the same thing in the prostate. So the thing that transformed early detection of prostate cancer is the PSA blood test. And so a man who's thinking about early detection to avoid the consequences of, because again, it's no symptoms until, generally speaking, it's spread. Wow. So a man who's concerned, and there are some high-risk states that may be more concerned, really it's a matter of getting a PSA test. And if there's concerns on the level of the PSA test, seeing a urologist.
Okay, that's clear. I understand that very well. Now, at what age should a man consider going to a urologist, getting a PSA exam, having a digital rectal exam? What's the guidelines?
There's a complicated answer to that. So generally speaking, until you're about 50 or 55, the risk of prostate cancer is pretty low. And so testing for PSA at lower ages puts you at risk of having unnecessary testing and biopsies and so forth. On the other hand, there are certain groups who may want to begin earlier, such as African American men, who tend to develop prostate cancer earlier, and their risk is higher, and their risk of dying from prostate cancer is higher. We don't really know why that's the case. And men who have a strong family history of prostate cancer. So I've seen folks in whom every man in the family is diagnosed with prostate cancer, multiple people dying from it. And those folks, you may want to start as early as age 40. And there are some genetic tests that can be done to look for, there's some kind of genetic syndromes or variants that can go through families. And the other consideration is if you have a strong family history of breast cancer, like multiple members of the family with breast cancer, the men in that family may want to consider earlier testing for PSA as well.
Wow, okay. Good to know.
But a discussion with the doctor is a good thing to do.
Family doctor or get to your urologist?
Family doctors, many of them are exceptionally well versed in this and can have very sophisticated discussions. But a family doctor oftentimes has to know about cholesterol and blood pressure and screening for depression. And I don't know how a family doctor can keep it all.
I don't know.
It's just amazingly complicated. So thinking about maybe, if you have a strong family history, African American, maybe having a urologist when you're 40 or 45 and seeing them on an annual basis, and then maybe about the age of 50 or 55, establishing a relationship with a urologist, seeing them on an annual basis. We're good guys.
Yeah, it's true. Okay, now let's say that they get their PSA test and the PSA comes back high. What are the next steps? Because that's pretty scary.
It is. But just we always have to remember that if a man is being tested for PSA, if the man is ultimately found to have prostate cancer, most of the time, the vast majority of the time, the man's cured. So it's kind of what's the worst thing that can happen is, from a cancer standpoint, is that generally speaking, you'd find a cancer that poses you a risk, treat it, and cure it. So, but if a man is found to have a single PSA test that's higher, and we can come to how you interpret it in just a moment, oftentimes the best thing to do next is simply repeat it, because you can see tremendous variations in the PSA. I never make a decision on a single PSA test. And for example, in our studies, we see folks that have a PSA annually, and it's 1,1,1,1,6. Well, certain things can cause more PSA to leak out of the prostate. And so the simple thing to do after that is just simply repeat it. And oftentimes it comes back down again. So never act on a single PSA. Then the question is, how do you interpret that PSA? On the piece of paper, it generally says, if your PSA is above 4, it's abnormal. We now know that that's a simplistic evaluation of PSA, because it's not just, for example, your cholesterol that tells you about your heart attack risk, because if your cholesterol is a little high, and if you smoke and your dad died of a heart attack and your father died, and your grandfather died of a heart attack, and you're overweight and so forth, that person's risk of a heart attack is a whole lot more than the marathon runner. Everybody in the family lived to be 102, and so just like that, the PSA. So the PSA gets coupled with age, race, ethnicity. So African Americans a little higher risk, and if we say Caucasians have this risk, Hispanic Americans a little lower risk, Asians a little lower risk beyond that. Your age is associated with your risk, your family history, what the prostate feels like. All of these things play a role, and there's several online risk assessment tools. The one we developed for the Prostate Cancer Prevention Trial is called the Prostate Cancer Prevention Trial Risk Calculator. You can just Google that, you go directly, put the information in, and it gives you your likelihood, if you have a biopsy, that you'll find prostate cancer.
I was going to ask you about that calculator. That sounds like something for somebody like me, because I need user-friendly information where I can just go plug in, answer questions, and the calculator will give me some kind of idea of, well, what should I do next? So tell me again, what is that website?
So if you just Google Prostate Cancer Prevention Trial Risk Calculator, it's the top hit, click on that, it takes you to it. There are other calculators that are out there. There's a European calculator, there's a prostate biopsy collaboration, and they give you different kinds of risk because they used different patients. Our study was probably the most unbiased population, but they all give you a generalized risk of finding prostate cancer. Helps the doctor have a conversation with the patient. So, for example, if the doctor feels a bump on the prostate and the PSA is really low, general guidance is if you feel a lump, you ought to biopsy it. But if the PSA is really low and all the other risk factors are quite low, the likelihood that that's going to be a cancer is going to be really low, and that patient may decide, I don't want a biopsy. On the other hand, remember, a PSA above 4 is abnormal. Now imagine a PSA that's 3.9 in an African American man who's 73 years old, whose father died of prostate cancer, who has perhaps a little bit of an abnormal his prostate exam, his risk of prostate cancer is very high, and his risk of aggressive prostate cancer is high as well. So that man with a normal PSA may want to consider further testing. Just like the cholesterol. You don't use a single number for cholesterol, you incorporate the entire patient's history and risk for heart disease in interpreting it as well.
So that kind of leads me to another question. Because you have so many patients coming in for prostate problems, issues, I would have to believe that all of them, deep down inside, have a deep fear of prostate cancer. Mm-hmm. So of all the prostate issues that you see during the day with your patients, what is the percentage that they could actually be a cancer versus everyday issues of the prostate aging?
Yeah, so it's important to think about this as we steward healthcare resources, because I think we as physicians need to be really careful about how, healthcare is what, 18-20% of the gross domestic product?
Yeah.
We use a lot of resources for healthcare, and that's why it's so important to best individualized healthcare for folks. So the challenge with prostate cancer is that as we as men get older, the likelihood that we have prostate cancer goes up a lot. We know this from studies of men when they die. I mean, I'm 60, I think I'm 66. There's a 2/3 chance I have some cancer cells in my prostate. A 75-year-old man, 75%, more or less. On the other hand, a Caucasian man in the United States, his lifetime risk of dying from prostate cancer is between 2 and 3%.
Oh, that's so low.
Yeah. And right now in the United States, your lifetime risk of diagnosis of prostate cancer, it varies from year to year, maybe around 12 to 15%. So maybe 3/4 of us have it. About 1 man in 6, 1 man in 7 will be diagnosed, and about 2 to 3% will die from it.
Wow, that's a very encouraging number.
Very encouraging. On the other hand, getting up at night, slowing urinary stream, maybe you're washing the dishes, you get the urge that you have to go all of a sudden. Those kinds of things, 50, 60, 70% of men will have those. Okay. So the majority of the time, it's not a prostate cancer. But we have to remember that of all the cancer risks, it's between lung cancer and prostate cancer, it's neck and neck as to which is the one that takes the most lives in the country.
Wow.
So it's a very important, and as men get older, the cardiologists take care of us and we live longer and those sorts of things. As we get older, our risk of dying from prostate cancer goes up. So it's very important.
Wow, that's a lot of information. Speaking of a lot of information, we live in the age of the internet. So I know, guilty as charged, I'm always Googling everything medical on the internet. Of course, I'm married to a doctor and I'm like, oh my God, did you know this? And he's like, what are you reading? So as a urologist, what is your challenge with patients today, because they're bringing in non-scientific data from Google and ensuring that they get the proper care and understand what is scientifically true?
It's a challenge. It's really a challenge because And I encourage my patients to look these up because it leads to very good questions. But the concern that I oftentimes have is, who are you going to trust?
Yeah.
Dr. Google or me? And for example, in the use of supplements and other things, we have to remember that much of what you read on the internet is advertising. And I'd say this is a capitalist society. We're trying to drive folks towards using their resources for things. So it really, and it's very difficult. I mean, even for me, when I'm reading a published paper on a clinical trial, you have to get down into it to best understand how to interpret the information. Unfortunately, when you look at script on a website, especially a website that's sponsored, you can take, I mean, for example, let's just say someone has a supplement that's to be used for prostate health, and doctors recommend it. Well, who are the doctors that recommend it? Our studies show, well, if you take almost anything, I tell everybody, if you take peanut butter and you mix it in a bunch of prostate cancer cells, it will probably kill those prostate cancer cells, right? Or cucumber extract, it will probably kill the prostate cancer cells, or shrink a prostate in an animal. Doesn't mean that it's going to do that in a human. So really, the going back to kind of the most important thing is, have a physician that you trust bring the information from the internet with you, write down the questions, and ask about it. Because those are the folks who are best able to sift through the mountains of information. National Library of Medicine, if you look up prostate cancer, National Library of Medicine, hundreds of thousands of publications, millions of publications on it, and it's growing exponentially. And even for experts like us, it's very difficult to sort through for truth. And so there are some organizations that, for example, the American Urologic Association, the American Cancer Society, other organizations that come up with recommendations. They put people together, extract the information. It's a huge amount of effort to develop guidelines, and that's a good source for it as well.
Okay, wow, that is such a vast frontier of information. Sifting through it is so challenging. And I'll give you an example. My 92-year-old father, almost 93, he watches TV, of course, a lot after his 18 holes of golf, but he's always watching the commercials for the prostate.
Sure.
And he's always telling me, honey, I need to order that because that says that it will help me.
You bet.
And the TV, every sports channel, every news station, they keep advertising supplements. So what is the myth about supplements and vitamins? And is there anything that helps?
Well, this could be a 2-3 hour discussion. When we began the prostate cancer prevention trial, the drug that we used, finasteride, which reduces a man's risk of prostate cancer by about a quarter, we now have 25-year follow-up of these 18,000 folks, and it's persisting, 25% risk reduction. Shortly after we began that, there was a lot of information on the two most promising supplements/vitamins. One was vitamin E, large clinical trial conducted in Scandinavia for lung cancer. Men were randomly assigned to receive vitamin E or placebo, and there was a significant reduction in risk of prostate cancer in the men. Now that study was a lung cancer study, not run for prostate cancer. And of the multiple analyses, they found that vitamin E reduced the risk of prostate cancer. Another study for skin cancer run out of Arizona, again, a skin cancer study, looking at selenium, which is a trace element, and it is a component of something called glutathione peroxidase, which is an antioxidant, just like vitamin E is. So the thought was antioxidants reduce risk. At that point in time, 75% of men in urology practices across North America were taking vitamin E.
Wow.
Because it was recommended, and they still do. If you go to a health food store or wherever and you look for men's health, you'll oftentimes find vitamin E and selenium in them. So the National Institutes of Health, the National Cancer Institute, embarked in a large-scale clinical trial, which I helped design and help run, called the SELECT Selenium and Vitamin E Cancer Prevention Trial. And we randomized almost 35,000 men. And guess what we found?
What?
Vitamin E increased the risk of prostate cancer by almost 20%. And selenium had no impact at all. And those are the two most promising. Another common supplement that's found in these over-the-counters is saw palmetto. Anybody who's seen a late-night show about saw palmetto, you can buy it and take it. It's the only other one that I know of that's been tested in a randomized trial where you either get saw palmetto or placebo. And saw palmetto and placebo were equally effective. So the short story is I tell folks, I live in San Antonio. Our kind of hometown grocery chain is HEB. And I always tell folks that if you want to take a supplement to reduce your risk of prostate disease, you'll find it in the produce aisle of HEB. Made by God in the form of broccoli or tomatoes, those sorts of things. We know that there's a huge amount of important nutrients. And in general, someone who's taking a well-balanced diet, especially a diet with fruits and vegetables, their overall cancer risk is a lot less. So I tell folks, throw away your supplements unless your physician has recommended it. There are some, maybe for the eye, some vitamins for the eye and so forth that may be appropriate. Baby aspirin, we used to think everybody should take a baby aspirin.
Yeah.
We now know unequivocally baby aspirin increases the risk of cancer.
Wow.
So only people who have been recommended to take it by their physician should be taking it. So again, a well-balanced diet is the best form of vitamins and supplements.
That leads me to my last question, because I was going to ask you, if you wanted to leave our audience with one message or a piece of information that would be helpful to them with regards to prostate health, what does that message need to be?
Can I do two?
Yeah.
So one is stay healthy. In general, a healthy lifestyle, exercise, watch your weight, and a well-balanced diet reduces the risk of virtually every disease that we deal with. Diabetes, hypertension, stroke, heart disease, cancer, all of those. So when you get up in the morning, out for a walk. You can come walk with me early in the morning. A well-balanced diet, watch your weight, and get enough sleep. Those sorts of things are the best way to prevent disease. And then the second thing, like we talked about earlier, if you're a man, especially if you have risk factors, African Americans or men with family history and so forth of cancer, I would say think about maybe age 50 or so, asking your primary care doctor, who is your trusted colleague in your health, should I be seeing a urologist on a regular basis? And that can then lead to these kinds of discussions to not just evaluate your prostate cancer risk, but also someone who can help with urinary symptoms and sexual dysfunction and all the other things that urologists work with.
Wow, great information. Dr. Thompson, this has been outstanding.
What a treat to be with you.
Wow, thank you. I have a million
And what a great
questions.
book. Congratulations.
Thank you. Yes, I married a urologist, and I did. I want to thank you so much for your time today. You have been beyond generous with
My
your
pleasure.
information.
Nice to be with you.
I really appreciate you. And for all of our audience, thank you for watching us today, and we look forward to seeing you on our next show.
Thank you for listening to I Married a Urologist with Madeline Zech Ruiz. Please push the subscribe button below the screen and leave us a comment. For more information on urological questions, feel free to contact us through our website, www.imarriedaurologist.com. And be sure to catch our next fun and educational episode on all things urology.